Welcome to the virtual trauma meeting. The aim is to provide a friendly environment for open case-based discussions with the help of orthopaedic trainees and consultants to build upon orthopaedic knowledge and experience for undergraduates. Please could you present the case for us?
This was a 33-year-old man who presented to the emergency department who slipped on some wet leaves and inverted his ankle, felt immediate pain in his leg and was unable to wait there, so called an ambulance. He's a fit and well man, aside from the fact that he drinks about 5 beers a day and a little bit of vodka as well. He is a Lithuanian chap who works as a builder, lives alone, is a non-smoker, and he presented with this injury, which was closed and neurovascularly intact.
And he just slipped on some leaves?
Yeah, and put his whole weight through the leg.
Okay, I'm concerned about that because that's a low energy mechanism for this type of fracture.
I think maybe his alcohol history might tie in with that a little bit.
So what I'm driving at here is that if you get a low energy injury resulting in this sort of fracture, then sometimes you need to think about whether or not this was painful before and it's been painful for some time and there was some abnormality in the bone that he's fractured through. I mean, looking at it, it all looks straightforward as a regular fracture of his right distal tibia. And he drinks 5 beers a day and has done that for some time?
Yes, that's correct.
So what do you think that might predispose him to? Good for bones or bad for bones?
Bad for bones.
Now, we just been temperate, or is there a biological reason? You get liver failure, generalized osteoporosis, just poor diet. You know, there's a whole raft of things that go if you've got a chronic drinking history. But I think at 32 with 5 beers, yeah, we might be being a little bit forensic about it. So what does it look like, or what are your responsibilities or your thoughts, Catherine, when you see this man in the emergency room?
So initially, I'd want to make sure that he has the limb immobilized to keep him comfortable. You'd want to put him in an above knee back slab just to immobilize the limb. So you'd want to do a whole A2E assessment. You'd want to make sure that this was an isolated injury. So do a secondary survey, make sure that nothing else is painful. And if there is, do more x-rays. Make sure there's no evidence of a head injury. With the alcohol history as well, you might want to just not take the history on face value and be suspicious of a head injury. So you check the limbs, his right leg, you'd be checking the skin, looking for any areas of skin puckering or areas of blanched skin that sort of might indicate that the skin could become threatened at the area of the fracture site. The skin at the front of the tibia is very thin, and so with this type of injury, it's common to see damage to the skin that would be an open fracture, and that would change your management. And then you would make sure that the sensation in the foot is normal. He can move his toes, and that doesn't cause him increased pain, because with this type of fracture as well, you would be thinking about compartment syndrome. So any fractures in the lower limb and a tibial fracture, you need to be thinking about compartment syndrome. So you'd be looking at how much pain the patient's in. Any pain that doesn't respond or improve with analgesia and having the fracture immobilized, you'd be concerned about. So pain out of proportion to what you'd expect for this fracture.
How would you see that? What would you be looking for? In
terms of pain, well, I think somebody who can't sit still, somebody who is unable to sort of speak to you and answer your questions because the pain's so distracting, somebody who's rolling around in bed.
And you're going to speak to the nurses as well and ask them, I mean, is this guy asking for more pain relief and you're having to give him more and more pain relief? Look at the drug chart. Has he had far more pain relief than you would expect for this type of injury? And those are the clues that you start to think, hang on a minute, there is something more going on here than just a simple fracture. This guy could be developing a compartment syndrome.
So compartment syndrome is where the pressure in a sort of fascial compartment is greater than the pressure that the capillaries are perfusing the tissue at. So the pressure that you need actually to stop perfusion across your capillary beds is not that high at all. So if the pressure in a compartment exceeds that, then the tissues won't be being perfused to become ischemic or later on sort of necrotic. The pain on passive movement is a key one. So in this, you would take the big toe and you would flex and extend it, which would be stretching the muscles in the compartment. And if that causes an increase in pain, then it's highly suggestive of a compartment syndrome. Later signs would be paresthesia, or change in sensation of the limb distally, pallor, so if the foot becomes dusky looking, or if there's a lack of a pulse distally as well. Those would be late signs, but very concerning signs of vascular damage and compartment syndrome.
That's a great answer.
So initially I'd want to immobilize it using a back slab. I'd also want some imaging more proximally of the leg, because we haven't actually imaged the whole leg.
That's great.
So that fracture of the proximal fibula there may cause some disruption to the common perineal nerve.
Good. So where would you assess that?
The deep perineal nerve supplies the first web space of the sort of dorsal aspect of the foot, so between the big toe and the second toe, the web space there.
Yeah, and that's probably due to just some edema, localized edema from swelling from the fracture, so it's going to bleed into that area, and it may have taken a bit of an impact when he fell, and so you might get some paresthesia, some altered sensation in the first web space because of that. Are we worried about that fibular fracture?
I mean, it looks like it's probably in at least sort of 3 pieces, so it's a bit comminuted.
Yeah.
But generally,
overall, he doesn't do much weight bearing through his fibula. We're going to concentrate more on the tibia, aren't we?
Yeah, exactly.
Good. Okay. So, and are you telling me that this tibia fracture, is it just isolated to the shaft, or does it go anywhere else?
So I think it's just isolated to the shaft. On the previous X-ray, it doesn't look like it continues down into the ankle joint. But if you were suspicious of that, you could perform a CT scan to visualize that further and see if it does indeed go into the articular surface.
Yeah. So what we're going to do, we get a CT scan to see if it would do that, if we were concerned about that. So we're going to have a conversation with this guy about the treatment options available to him, aren't we? Because he wants to get back to work, I presume, as quickly as he can. He's got a livelihood that he wants to maintain. He's had some images taken once the plaster's been put on. As we said before, anyone who has a plaster applied, whether it's taken off, put on, gets x-rays afterwards, because you want to see what's happened to the bones. Have they changed position? And yes, there has been a little bit of translation, but the overall alignment on the lateral is pretty good. On the AP, could be better, but it's hinged on that's going to be fine overnight. Does he need an operation? Yeah, yes or no? If so, why so?
He'll be able to weight bear.
He can walk in it straight away, he can get going, and he can get back to work sooner. So he may decide he doesn't want an operation, he wants to keep it in a cast, and it heals. He could either have a nail, he could have a plate, or what we call an open reduction internal fixation, or a frame, either with wires or pins which go into the bone, and they create a cradle on the outside, a cage or a cradle. You might have seen some of them walking around. And you can fully weight bear on certainly a nail and a frame. A plate, you might not weight bear them straight away, but you'd certainly get them going sooner than if it was non-operatively managed. The only issue with the frame in this guy, I think, is the fact that he works on a building site. So the risk of getting an infection is pretty high and probably not the most suitable in that respect. Plate, as we've said, he probably wouldn't be able to weight bear straight away. And the option that I would put to him would be the most reliable and predictable way of getting him back walking and back to work soonest with this fracture healed would be for an intramedullary nail. But that's a conversation that we'd have, and it's all about shared decision-making, his thoughts, his social, personal work circumstances, and what he wants. He doesn't have to have an operation if he doesn't want one. So what I've tried to do is outline what I think this guy might want, but it's important that he knows what the different options are so that he can apply them to his circumstances, so that he makes the decision based on all the available information, so that it fits in with his work circumstances, his social circumstances, his personal circumstances, his health beliefs. All of those things come into play, and it's his decision. And my role is to provide him with enough information to make that decision, given all those different categories that might affect his life. The problem with this part of the body is there's not many muscle attachments to the distal part of the tibia. And down here, there's far fewer muscle attachments than around the thigh, for example. So actually, the blood supply to this is quite poor. So what we want to do is to line it up and stabilize it to give it the best chance of healing. He doesn't smoke, which is great, because that is thought to affect bone healing. But if we can give him the right mechanical stability, as in he's got a nail which stabilizes the fracture. So the nail's going to come inside the bone. Obviously, we're going to measure his canal to know that the nail's going to fit inside it. The nail's going to come down once it's been reduced. To line that up, you would reduce it, and then obviously you would want to correct that translation, pop the nail down from the knee downwards, and then you lock it with some screws or bolts at the bottom and up at the top as well.
So post-operatively, having had this fracture moved around and reduced for the operation, there's going to be some sort of soft tissue swelling. So again, you'd want to monitor him for compartment syndrome. So limb observations, which basically just mean checking the sensation in the foot and that it's nice and pink, and as well monitoring the patient's pain post-operatively. If he's had a nail, then he will be able to weight bear on it. So physiotherapy, occupational therapy. Also, the fracture is stabilized by the nail. Bone healing around that would probably take sort of 6 to 8 weeks.
One of the things that we get into a bit of trouble is we're all optimistic people, and we want things to happen quickly, and we sometimes give people over optimistic goals early on, which take an awful long time to straighten out later. So the advice generally is not deliberately pessimistic, but if I was being asked by his bedside, I'd say you probably won't be playing football to the same standard for more than a year. He may not play football, but it's quite a good analogy. If he gets better and he's playing in 6 months, he'll laugh at me saying I'm a fool, and I can live with that. But if I say 6 months and he's not doing it, it's going to be very, very difficult for him, because he'll think something's wrong when it isn't. He'll think he's slow. He'll be frustrated. So, some people may say that's being disingenuous. It's a white lie. I think it's just a pragmatic way of dodging the question. So just always be slightly pessimistic about recovery time for these fractures, because what we base it on is when we look at an X-ray and it looks healed. But what he's actually asking is when the impact on his life will be minimal or zero, and that's much, much longer.
Well, it's a fairly safe time frame to say that it'll be 2 years before you forget about it.
I think that's fair, and people need to know that early on, and they'll live with it and they'll process it. But if you say 6 months and at a year they're still struggling, it's very difficult then to retrieve it. It's just easy to get this out of the way at the beginning. The reason I bring it up is because it's a consistent cause of difficulty.
Yes, absolutely. But reasonably, I would expect him to be back at work within somewhere between 3 to 6 months.
Catherine, I think you gave some absolutely fantastic answers there. And the other thing is there any way we can convince you to do orthopedics for a career?
I'm being slowly turned.
I think your answers were absolutely fantastic.
Thank you for listening. We hope this has been informative. If you have any questions or suggestions for further programmes, please contact us at thegrandacademy@btinternet.com.